study design. So we see that we can measure the different cases, and we can measure the prevalence and the incidence of disease from our different studies. But now, what is the design that we might use in order to be able to do an epidemiological study for mental health, or for anything else, in fact? And we can have some, it's important to have the correct design for the output or for the measurement that you want to look at. And what I'm going to do is sort of have a look at different designs, say that we need to be as accurate as possible in measuring not only the outcome. If we're looking at depression or anxiety or trauma, then we need to measure that as accurately as possible. But we also need to measure exposures. If we're going to be doing an epidemiological study where we're going to be looking at risk factors for a particular outcome, we need to measure our exposures with as good as accurately as possible, that we can have that. And the third point about study design is that we need to measure a lot more exposures, because some of those exposures might be confounders. And I'll just mention this in passing. I'm not going to go into confounders in detail, because we can confounders. The importance of measuring other exposures that might influence that outcome, then that is important, because those other exposures might be confounders, or they might be independent risk factors for our outcome. And both of those are going to be important if we are going to understand what it is influences the outcome that we're looking at. So in an epidemiological study, there is an outcome of interest, which, if it's mental health, it might be depression or anxiety or trauma or something like that, psychosis. But there's also going to be exposures that might be of interest, risk factors, which might be, they might be causes for a particular outcome, or they may be risk factors that are predispose someone to that. So we need to measure all of those as accurately as possible in order to be able to do our epidemiological study. What do we mean by exposures and outcomes? So I've just introduced this term exposure and outcome here. And the definition of both our exposure and our outcome depends a little bit upon the question that we're asking. But the outcome is the event or condition that we want to be looking at in the first place, which might be something which is to do with mental health, but we'll see in a minute, it might be something else that is a consequence of poor mental health. And the exposure that we might want to include in our hypothesis, that is, does a particular thing, does stress cause anxiety, or does stress cause depression, or does a marital breakup cause depression? And all of these things will have a primary exposure, and we want to look and see whether that is a cause for the event that we're seeing in our study. However, we might have that exposure and our outcome that we're looking at in our study, but we need to be able to collect a lot of other variables or exposures or covariates or many other ways of talking about these. These might be independent risk factors for the disease, the outcome, and so therefore they might be something which is important to know about in order to assess the factors which are contributing to that disease. But they may also confound the association between our primary exposure and the outcome. And that's something which we need to think about before we even start collecting the data, so that we can have a set of exposures that we are looking at. So here's a question that we might be interested in. We might say we're interested in looking at the relationship between depression and brain cancer. Depression is a mental health condition, but brain cancer is another condition which may or may not. And we might be asking ourselves, what is the outcome here? Are we looking at depression as a cause for brain cancer, or are we looking at brain cancer as something which would lead to depression? And so there are two different ways of looking at this. One is could be have an outcome here as brain cancer, and we're looking at depression as a cause or a risk for developing brain cancer. And the other one, well, let's look at our outcome being depression. Do people with brain cancer have greater levels of depression? And so we can have two different questions, two different studies there, which would be looking at the direction of the causality between these two different conditions. And the other thing to note here is that if we're looking at one question, we might have a set of exposures which are independent risk factors for that particular outcome, and we might have particular potential confounders which are looking at that as well. But if we're looking at the other question, then the set of exposures that we want to look at might be very different, and they might be something that we would have to consider. So depending on which way round the question depends on the exposures that we might want to have a look at. Okay, I can see that a couple of people have raised their hands. Amos and Caesar have still got their hands up. Are you still wanting to ask questions, or are you going to put down your hands, right? Don't get
Yes, I want
confused.
to ask a question.
You want to ask another question? Who's that? Caesar? No.
Sorry.
Yeah.
I want to add you back a bit about confounders.
Yes.
I don't know whether confounders you can have a one-size-fits-all approach. Like you could use the same methods in clinical kind of conditions or settings, or you use the same in epidemiological, or you could have different methods in both. For example, maybe just to give a scenario, in which part of the two would you use directly or directed cyclic graphs?
Okay. So directed acyclical graphs, or DAGs, are used in a lot of causal research, a lot of causal analysis, where we're looking at causes which might be leading to a particular outcome. And of course, confounders are very important in that. And those confounders might affect that causal relationship that you're looking at there. I don't think there's ever going to be a one-size-fits-all. There's never going to be saying, well, we have to look at these exposures, and these are the exposures which are important there. I think there's a lot of exposures which can be important at certain times, but not necessarily in all circumstances. So it might be that we'll have to, sort of like consider that. But the important thing at this stage in developing your epidemiological question and being able to answer the to be able to get a good study design is to say you do need to be able to measure lots of exposures, even if some of them may or may not be confounders and some of them may or may not be independent risk factors. You do need to measure them so that you can include them in your analysis, and then you can take into account the way that they might affect your result. So in the chat, what do we say there? Which is the correct design? Okay, well, we'll come on to different designs. I'm not going to tell you one design is better than the other. It depends on a lot of different things there. Abdic says that confounding is mediation variable. Yes, that's one way of looking at it. It changes the effect that you might have between one variable, between independent variable and the dependent variable, independent variables. Yeah. So the association that we see in a crude effect or in a univariate or bivariate effect might say that there is an association between these dependent variables, this dependent variable and these independent variables, but confounding might change all of those, and it might show that that is not true after you adjust for other factors. Yeah. Okay, good. So let's have a look. Let's carry on then.